This is an interesting case. The client came to see me from Washington, D.C., and she has a 6-year history of what she calls sacroiliac joint pain. And this is related to a fall onto her buttocks. And she also has a long history of feeling unsteady on her feet. Can you give us a brief description of that?
Well, I've always felt like I kind of need to hold on to things in order to, like, I can't run. I can't run on a treadmill because I'll tip over to the side. I just feel unsteady.
Okay.
Yeah.
And you have a history of playing tennis.
Yes, and I played a lot. Yeah, I played a lot of tennis for a few years. Yeah, but I did sprain my ankle. I want to say 4 or 5 times in high school.
And that would be your left ankle.
I can't remember. I'm
Okay.
too old. I can't remember.
That's fine.
Yeah.
Her body type is one of slight laxity. I can hyperextend her knees on both sides. Her 5th metacarpophalangeal joint goes to 90. Mine goes to 45 and protests. But her ankles are rather rigid. Same for her subtalar joints. And there is a greater sprain pattern in this left ankle. I don't want to spend too much time. I want this to be a fairly brief video. But both ankles come up only to neutral, only to 0 degrees of dorsiflexion. They should move to 15 to 20 degrees of dorsiflexion. So we want to work on gaining that mobility. The subtalar joints are very rigid, going into eversion and going into abduction. The left foot has greater inversion than does the right, and this fibula appears to be inferior. That's all I want to say about foot and ankles. Clearly we need to work on them to gain some mobility. And I want to now talk about her pelvis. So I'm going to demonstrate a couple of spring tests. We can move the camera up over there. Now you had a surgeon look at you and do the general mobility test where you stand and you lift a leg, and you bend forward and such, and you looked at how the pelvis moved. And on that basis, he said that you might have some sacroiliac joint hypermobility.
Exactly.
Okay. Well, I have to disagree with that. Those tests really don't measure motion inside the sacroiliac joint. That's a whole other conversation, and I've already had that conversation. I'm not going to belabor it for the purpose of this video, but your pelvis, when I try to induce movement through it, it's extremely rigid.
Yeah. It
feels like a block of granite. And while I was testing you, and I didn't even make that comment, you were on your stomach.
Yeah.
Hips have excellent mobility, all directions, but the pelvis itself is very rigid. Go ahead and lay on your stomach. And what did you say about your...
I said that this has always felt like it was a block of solid wood all the way across.
Okay. And that is a perfect description. For the simple fact that I'm isolating the PSIS, I come on your sacrum, there is no yield when I do this test. You're young, healthy, and you have good mobility throughout the rest of your body. I can spring along your spine, and I can load it and spring it, and there's recoil. There's good movement throughout all your extremities and again through the hip. But when it comes to the pelvis, this is like a block of granite.
So that's not normal, huh?
This is not normal. I should be able to load this. I should be able to get some forward spring and then some recoil, and I can't even load it. Yeah. There's just no motion. And the same is true at L5. This junction is the L4, L5 junction. This is 5, and I can't get motion there. And I come up to L4, and you can see that I can load this, and I can give it a little thrust. There's a forward movement, and there's a recoil. What we find is that the sacrum is positioned posteriorly. When I'm on the PSIS, I actually climb up onto the sacrum. And this is a typical pattern that I've discovered that commonly occurs with the fall onto your buttocks. And the other possibility is delivering a very large baby. But your sacrum is positionally posterior. Okay, my right thumb on the sacrum is much higher than my left thumb, which is on the PSIS. I don't think the camera can capture that, but there's PSIS, and this thumb is much higher. Okay, the sacrotuberous ligaments are rock hard. These are supposed to yield like a ligament, have some elasticity, but these feel like bone. The other thing I want to demonstrate, let's have you lie on your back, and we're going to demonstrate the rigidity in your upper cervical spine. Very common with this pattern is an upper cervical rigidity. Now I'm going to put my thumb down at C2, and I'm going to spring it, and you can see her head moves very freely. I can spring on both sides very freely using just minimal amount of force, less than 5 pounds. When I come on to C1, this is rigid. I'm not able to easily spring it. And now when I get on top of the mastoid and I try to induce rotation of the head on the neck, very rigid on both sides. When I try and traction it, very rigid. When I try and lift your head up, because the occipito-atlantal joint is very restricted, hyperextended, I cannot easily lift your head up using a normal amount of force, which is about 10 pounds. When I try and traction your upper cervical spine, I should see movement translated through the whole body, but I have to use an excessive amount of force to induce motion. And this is a reflex phenomenon up here. This may resolve very nicely, just reflexively resolve, when we restore motion in the pelvis and restore motion in the foot and ankle subtalar joints below. So this is our interesting case, and what I name it, of course, ignoring the ankles, is that the pelvis is very rigid with a posterior glide fixation of the sacrum, and I'm on the outside looking in, and this is the best that I can do. We could argue about nomenclature, but certainly this pelvis is very rigid, and we're going to gain mobility in the pelvis, same thing with feet and ankles, and gain mobility up here as well. So I think we've talked long enough. I don't know how many minutes we are, but it's a good time to stop. We'll stop. Thank you very much.